Welcome back. Let's talk about neuroanatomy. This is part two. So if you haven't watched part one, go back and watch it. I just want to remind you that for the CLTM, you don't need to be an expert in neuroanatomy. However, when you look at the handbook, neuroanatomy is just a small percentage of what they're testing, right? Like if you look for neuroanatomy questions, like straightforward neuroanatomy questions, there are not going to be that many, or they're not going to weigh that much. But the knowledge that you're going to get from these two presentations about neuroanatomy, if you understand it, if you understand the concepts, and then you're going to be able to apply it when we talk about in week three localization, and when we talk about semiology, and when we talk about mapping. And I believe I mentioned that in part one. So make sure that you understand everything that it's included in part one and part two. And then if you want to go ahead and study more in depth of neuroanatomy, that's fine. That's up to you. I just want to give you what they're going to expect you to know for the CLTM. Okay, so to start, I want to present to you the homunculus. So the homunculus is just an image representing what each cortex is going to be covering, what parts of the body are the signal to what part of the body is that cortex responsible for. So this image, you might not be familiar with it because this is something that you really don't need to when you're taking the REEGT exam. But if you went to school for neurodiagnostics, or if you've done nerve conduction studies, or evoked potentials, then you might be familiar with this image. But if you're not, then that's why I'm introducing this to you. This knowledge is very important, so make sure that you understand it. So to begin with, I'm not sure you can see my mouse, so I'm just gonna talk about right and left. On the right, we have the motor cortex, is in pink color. And in the left, we have the sensory cortex, which is in blue, grayish, I don't know, purplish. Um, so if you look at both images, is a hemisphere. Um, one is the right and one is the left. However, the motor cortex and primary cortex are both in both hemispheres. So this is just a representation of each cortex in a different hemisphere. However, you see that the hand, it's kind of at the same level in both cortices. And then the face and the head, and the face, not the head. And the face is also at the same level. And then the tongue at the same level in both cortices. However, if you look at the sensory cortex on the left, you see that the head is here, but then you don't see it on the motor cortex. And that's because there are no muscles in the back of the head. However, um, there is sensory fibers in the back of the head. That's why you have it on the sensory cortex, but you don't have it on the motor cortex. When you look at the medial aspect of both hemispheres in both cortices, you're going to see that there's a leg hanging down. Okay, so that means that there is there is motor and sensory information going to the leg in the midline. So both sensory and motor go in the midline for the lower limbs. Okay. And then you have the torso, which is kind of in the superior aspect of each cortex. And then you have the head for the sensory, and then you have the arm that's more lateral, right? The same for the motor cortex. And then you have the face, that is also lateral, and it's more at the inferior portion um, of that hemisphere. but it's before the Heschel's gyrus. If you can see here, this is the Heschel gyrus. So at that level, that's what I want you to understand. That is basically where you have your, if we're talking about the legs, it's going to be your CZ. And then if you're talking about the arm, it's probably going to be C3 or C4, depending on what arm. And then the face is going to be more temporal, okay? So that's what I want you to understand if we're talking about EEGs. But today we're going to be talking about blood supply, and that's why I'm bringing this up, because we're going to see how the territory of different arteries, when one of those arteries is affected by a stroke, how the motor and sensory functions of these parts of the body are going to be affected. So I hope you kind of understood that. So this is just the motor cortex, the sensory cortex. We also have the genitals here because the urination center is there by the midline. So these patients are going to present with incontinence if the artery that that supplies blood to the midline is affected. So that's something to remember too. But lower limbs is going to be there in the midline for both motor and sensory. Arms is going to be there on the lateral aspect of the hemisphere around C3 and C4. And then the face, it's going to be around that T3, T4 as well. And then you have the tongue, which is going to be more inferior. So now let's talk about blood supply to the brain. So the brain has a lot of arteries and veins, but I only want you to remember a few. Um, the arteries that come up to the head, to the brain, come from the aorta, and then they come up the neck and into the brain. So the very large one that we're going to talk about comes from the common carotid artery, and then it becomes the internal carotid artery. The common carotid artery has the internal and external, but the external is going to supply blood to the face, and the internal carotid artery is going to go up to the neck. So this one is going to supply the anterior brain, the anterior cerebrum. It's going to supply blood to it. And this artery is the one that is going to be most commonly blocked. And then the internal carotid artery and its branches. And then we have the vertebral arteries that by the name we know that has something to do with the vertebral column. So it comes up the vertebral columns and it enters the brain and it forms the basilar artery. So the basilar artery is the one that is going to be branching out to the posterior circulation, and then we have the anterior circulation by branches of the internal carotid artery, and it meets the posterior circulation by the basilar artery, and these forms the circle of Willis. And why is a circle? Well, it's the two circulations come together and have communicating arteries that form the circle. And this is what we know as collateral circulation. So if there is a stroke on any part of the circle of Willis, of the arteries surrounding the circle of Willis, then blood flow, collateral circulation is going to take care of that portion that is blocked and it's going to supply the blood, okay? So that's why it's important the circle of Willis. It's like if something happens at some level in the brain vasculature, then the circle of Willis is going to make sure that some blood gets to that region, okay? So here is a picture of the circle of Willis, and I put it side to side, side by side, with a like a sagittal section of the brain. And this is because I want you to realize that the circle of Willis is not a flat image like you see here on the left. This is just a representation. if you see the brain that is in that image with the circle of Willis on the left, you can see that the arteries that come from the vertebral column surround that medulla, and then they meet and they form the basilar artery. And then those branches of the basilar artery, which are the posterior cerebral, are going and the posterior cerebral are gonna go to the posterior side of the brain. And then the anterior cerebral artery, that one is laying kind of on this position of the brain, and then it goes up to the midline. So it's not a flat, it just goes up the medulla, and then the basilar artery forms, and then when it goes to the anterior circulation with the internal carotid artery branching out to the middle cerebral artery, and the anterior circulation is going to go up this way. So you can see it um, on the right, the image on the right, you can see how they go up the neck, and then they lay like in certain position. It's not flat. That's what I want to what I want you to see. And in this case, we only have one hemisphere, right? So we're looking at the medial aspect of what should be the right hemisphere. So you see how the anterior cerebral artery, it's going to supply blood to the midline over here, but not all of it, because then the posterior part or the occipital region is going to be by the posterior cerebral artery. So PCA, ACA, and we don't see the MCA here because MCA supplies blood to the lateral aspect of the hemisphere. So it's not pictured here. However, we have the cerebellum, and the cerebellum by the vertebral arteries, we have the, after it becomes the basilar artery, we have the pica and the aca, and these ones are going to surround the posterior, or it's going to go inferior to the cerebellum, the inferior portion of the cerebellum. The aca is going to be the anterior aspect of the cerebellum, and then the superior cerebellar obviously is gonna supply blood to that superior portion of the cerebellum. So just make sure that you know pica, ica, and the superior cerebellar are for the cerebellum, and PCA, MCA, and ACA go to the brain, to the what we know as cerebrum. Okay. So this is another picture of the territory of each artery. Here we have the lateral aspect, and here we have the medial aspect. So the yellow is the anterior cerebral artery, which is going to supply blood to that midline. And when you do a sagittal section, you're going to see that it's going to be supplying blood to that, all that midline there, okay? But if you go more lateral, then the middle cerebral artery is the one, this is the territory for the middle cerebral artery. And then more posterior is the posterior cerebral artery, which basically is gonna take care of supplying blood to that occipital region. And the cerebral blood flow and cerebral ischemia, it is very important that you understand or memorize this. Don't understand it. Just memorize if the damage is reversible, potentially reversible, or irreversible at what blood flow. So the normal would be 50 to 70 milliliters per 100 grams per minute. However, in some cases, you can still have normal blood flow or no symptoms or consequences at a cerebral blood flow of 35. But that's not the most common picture that, or the cases that you're going to see. So 50 to 70, it's normal. You're going to see a normal EEG. And then 25 to 35, this is when some changes are going to be observed in the EEG. So you're going to start losing the fast frequencies, the beta frequencies. But this is still reversible injury, neuronal injury. Then if you go lower than that, from 18 to 25, then you're going to start seeing some mild slowing. So it's going to be in the theta ranges. This is still potentially reversible neuronal injury. Then if you go lower than that, from 12 to 18, then you're going to see slowing that is lower. So it's going to be in the delta ranges. And this is still potentially reversible. However, anything under 12, it's going to be neuronal death. So less than 8 to 10, you're going to see on the EEG suppression of all frequencies. And that's going to mean neuronal death. Okay. Strokes. So we have two different type of strokes, and then we have the TIA. So the first two, ischemic, is when there's not enough blood flow, and not enough blood flow translates to not enough oxygen to the cell. So these could be caused by two things, by either a thrombus, or an embolus. So a thrombus is just a blood clot that is formed in the artery that is affected. Like is formed there and it blocks that portion. However, an embolus is a blood clot that is formed in other part of the body and it travels to certain place and causes a blockage. Okay, it could be a vein or an artery. So those can cause a blockage of blood flow, causing lack of oxygen to the cell. And we can have also intracerebral hemorrhage, which is a bleeding stroke. So a ruptured aneurysm could be a cause of intracerebral hemorrhage. And then we have the transient ischemic attack, which is the TIA or mini stroke. And this is just going to be a temporary interruption of blood flow to the brain. The patient is going to present with symptoms that look like stroke. However, all the workup is going to be normal. The MRI and the EEG are completely normal, and the symptoms are the patient go back to normal. Here I have a side-by-side representation of, on the left, I have the territory of each artery that we were talking about in a cross section, in a coronal cross section. And then I have on the right the image of the homunculus. So what I want you to understand from here is, depending on what artery is affected by a stroke, then it's the symptoms that we're going to see depending on what cortex is affected by that artery being blocked. So let's start with, here we see the anterior cerebral artery that I told you supplies blood to the midline. And then we have the middle cerebral artery, which goes through the frontal and the medial and the posterior as well, but it's just the lateral side of the hemisphere, okay? And then we have the posterior cerebral artery, which doesn't even have anything to do with the homunculus. So if the problem or the stroke was in the PCA or the ACA, we're not going to see anything related to the homunculus, okay? So the anterior cerebral artery, if there is a stroke, what's going to be affected if we remember the homunculus? The anterior cerebral artery is the one that goes and supplies blood to the midline. And as I told you, the midline, what you saw there was a leg hanging for both cortices, for motor and for sensory. So what are you expecting to see in a patient that has an ACA stroke? It's going to be sensory and motor symptoms in the lower limbs. So paralysis or sensory loss, numbness, hemiparesis, And urinary incontinence, remember that I mentioned that at the beginning, the urination center is right there by the midline. So anterior cerebral artery, it's going to affect the legs, the urination center, and it's going to be both motor and sensory. Now, because we're moving on to the middle cerebral artery, I want to do this exercise before I show you what the symptoms are going to be. So based on these, the middle cerebral artery territory is all of these on the lateral aspect of the hemisphere, down even lower than the Heschel gyrus you see here. So, for example, since we know that the Heschel gyrus is here, what if this patient has a stroke on these on the middle cerebral artery? Could it present with auditory problems? Most likely. If it's on the left side, it could affect Wernicke's area. It could affect Broca's area. So this patient could have aphasia. Also, if we're looking at the homunculus, we can see that the arms and the face are going to be affected. So this patient could have facial drooping, right? Because the muscles of the face are affected by the stroke on this artery, and they can have paralysis on the upper limb. So it depends on what if it's the right middle cerebral artery, then the left arm is going to be affected. The left side of the face is going to be affected. However, the language center is not going to be affected because it's on the left, and we're talking about a stroke on the right, okay? So that's the patient is still gonna have preserved the speech skills. But if the stroke was in the left MCA, then we could see some aphasia, right? And also we're gonna see weakness or loss of motor function on the right arm. So those are the things that you have to start correlating in order to answer the questions that they're going to ask you about these patients with stroke. So let's see, middle cerebral artery, the area of lesion is going to be motor and sensory cortex. It involves both. So it's going to be upper limb and face that we already said. And if it's in the temporal lobe, it could be Wernicke area or frontal lobe Broca. So all of these I already mentioned. And the symptoms are going to be contralateral paralysis and sensory loss of face, loss in the face and upper limb. Aphasia is in dominant hemisphere, usually is the left. And hemi-neglect if lesion affects non-dominant hemisphere, which is usually the right. And hemi-neglect is that the patient is not going to be aware of that side of the body. And we did that exercise, so we don't have to do it again. So now let's talk about posterior cerebral artery. So the posterior cerebral artery has nothing to do with the homunculus because it's not involved in the motor or sensory cortices. So basically, the posterior cerebral artery is going to supply blood to the occipital lobe. And we know occipital lobe, you should already relate it to vision. So what happens, the symptoms if the PCA, if there's a stroke in the PCA, so the patient is going to have contralateral hemianopia, and patient is going to have alexia without agraphia, and which means that the patient is going to be able to spell and to write, but unable to read. And then prosopagnosia, which is when the patient has difficulty recognizing faces or facial cues. So basically, it's going to have something to do with vision. And now let's talk about the basilar artery. So as I told you, the vertebral arteries will come together. There's a pair of vertebral arteries. They're going to meet and they're going to form the basilar artery. So the basilar artery is the one that is going to be laying there by the, it's gonna have some part in the pons, medulla, in the lower midbrain, okay? So the symptoms, if the reticular activating system is spared, then the consciousness is going to be preserved. And the reticular activating system is going up the medulla as well. So if that part is spared, then the patient is going to be conscious. Basilar artery also supplies blood to the corticospinal and corticobulbar tracts. So if it's affected, the symptoms are going to be quadriplegia, loss of voluntary facial, mouth, and tongue movements because of all of the cranial nerves that are involved there. And then ocular cranial nerve nuclei, pyramidal pontine reticular formation. Symptoms are going to be loss of horizontal but not vertical eye movement. So all of these symptoms together are going to give us a diagnosis of locked-in syndrome. The patient is conscious. The patient is aware. However, they cannot move a muscle, only the eyes, and it's just going to be um, they're just gonna have eye movements, okay? So the patient is conscious and awake, but has no ability to produce movement, which is very sad, right? And it's caused by damage to the pons of the midbrain, brainstem, and a complete disruption of the pyramidal tract, which is the one that has that connection between the the medulla and the brain, and or the spinal cord and the brain, and most of the cranial nerves. So here we have the ventricles and the cerebrospinal fluid. I'm sorry. So ventricles, these are these structures um, that are interconnected cavities within the brain that contains the cerebrospinal fluid, CSF. I'm just going to call it CSF. It's easier for me to pronounce. So there are four ventricles. We have two lateral ones, which are these ones, two lateral ventricles, and then we have the third ventricle in the diencephalon, or kind of there where the limbic system is. It's actually laying between the two halves of the thalamus. And then we have the fourth ventricle, which is in the hindbrain or the medulla. The ventricles are lined up by ependymal cells, and those are going to create the choroid, choroid plexus. And the choroid plexus is the one that is going to produce the CSF. Okay, so the ventricles are just going to be the cavities. And then we have the lateral ventricles, the third ventricle, and the fourth ventricle. Surrounding these ventricles, they're going to be ependymal cells that are going to form the choroid plexus, and the choroid plexus are the ones that produce the CSF. There are cerebral aqueducts and foramens. So the aqueduct is the one, it's also called the aqueduct of Sylvius. I guess Sylvius has a few things that he discovered of the brain, like the Sylvian fissure. And it's just a narrow channel that connects the third and the fourth ventricle. The third and the fourth ventricle. So that's the Sylvian aqueduct of Sylvian, or Sylvian aqueduct. And the function of the aqueduct um, is to allow cerebrospinal fluid to flow from the third ventricle to the fourth ventricle. This ensures the proper circulation and distribution of CSF throughout the brain and spinal cord. And then we have the foramen of Luschka and foramina of Magendie. And what this is gonna create is just a passage. Um, it's an opening in the roof of the fourth ventricle into the cisterna magna. And the cisterna magna finally is the main opening in the subarachnoid space. So again, there are four ventricles, two lateral ventricles, third ventricle, fourth ventricle. The ependymal cells are gonna form that choroid plexus that is going to produce the CSF. So the CSF is going to go through these ventricles and through the foramina of Magendie and Luschka, they're going to go to the cisterna magna, and from there it's going to go to the subarachnoid space, which is where you find the CSF. When they do a lumbar puncture, they have to get to the subarachnoid space to get that CSF. So meninges, there are three layers of meninges: the dura mater, arachnoid mater, and pia mater. And this is from the most superficial one to the inner one. So dura means hard in Spanish or Latin. So it's the hardest layer of the three. And then the arachnoid is the one that is in the middle, and the pia is the one that is surrounding, directly in contact with the brain. And the primary function, obviously, is to protect the contents of the brain and the spinal cord. So here you can see from exterior to interior, we have the dura mater, which is under the first layer under the skull. Then we have the arachnoid mater, and then between the arachnoid and the pia, we have the subarachnoid, and this is where the CSF, where the anesthesiologist has to get to, or whoever is doing the lumbar puncture to get that CSF. And then the PIA, which is the one that has that, it's sticking to the brain and it goes through the gyri and everything. So one more thing about the structures of the brain is the falx cerebri, and that's the fold of meninges between hemispheres. So if you see here, you see that there's a layer that goes in between both hemispheres, and that's the falx cerebri. That's that layer there. That's what we're talking about. Falx. I don't know if I'm pronouncing it right, but it's here. Just if you see it in the test, you know that it's in between both hemispheres. And then we have the tentorium cerebelli, and that one is just the tent of the cerebellum. So the cerebellum is here, and laying in between the superior portion of the cerebellum and the inferior portion of the cerebrum is the tentorium. So the last thing we're going to talk about is the cranial nerves. This is honestly something that I don't think I saw on my test, but since it's in the handbook, we're going to talk about it superficially. I don't think they're going to be very very specific about this. But the things that you need to know is that there are two cranial nerves that originate from the brain, and then the rest of them, the other 10 pair, are going to come from the brainstem. So olfactory nerve and optic nerve both originate from the brain, from the cerebrum, and where the rest of them come from the brainstem. And brainstem, remember, is the midbrain, medulla, and pons. So from the midbrain, we have the trochlear nerve, which is the 4. We have, that's the only one that is in the midbrain. But in the junction between the midbrain and the pons, we have the oculomotor nerve, okay? Oculomotor nerve is right here. So, and then we have from the pons, we're going to have the trigeminal nerve, which is right here, this huge branch, because this one will go to the face and has 3 branches, trigeminal. This one goes to the face. That's from the pons. And then pontine medulla junction, then we have from the 6th through the 8th. So we have the abducens, the facial, the vestibulocochlear. So those three we have that come from the pontine medulla junction. And then from the medulla oblongata, we have the posterior to the olive. So back here, we have the glossopharyngeal over here. We have the vagus, and we have the accessory. Okay, so, and then anterior olive, so coming from this medial part is the hypoglossal. So, if I remember anything, maybe they ask about which cranial nerves innervates the tongue. That's going to be the hypoglossal for movement, and that's cranial nerve 12. And then other question about the tongue is they ask you what is the polarity of the tongue. And the polarity of the tongue, the base or the back of the tongue is going to be positive, and the tip of the tongue is going to be negative. So I think that's all you need to know about the tongue, other than they're also going to ask you thirda, what could be confused with thirda, and it's going to be glossokinetic movement or artifacts. So, and they're going to show you one EEG with this artifact. So we're going to present that to you in future presentations. But just know that even though we don't talk about the tongue that much in EEGs, those are questions that I saw in my test. So cranial nerve 12 for movement, tongue movement. Polarity of the tongue is positive at the base and negative at the tip. And then thirda can be the artifact of tongue movement or glossokinetic movement artifact could be confused with thirda because you're going to see it in that frontal region and it looks rhythmic. So that's it. I think that's it for neuroanatomy. Just make sure that you understand everything, memorize whatever you have to memorize. If you have any questions, feel free to reach out to me or Annette. And I feel like this is all the neuroanatomy that you're gonna need to be able to answer the questions that involve neuroanatomy in your CLTM. So I wish you luck. I see you on the next one. Bye.